Good morning, everyone. Thank you, Richard, for that introduction. And also, I want to thank Julio for his presentation because it provides some good context for the next set of slides that you will be seeing. So I'm going to, over the next 12 to 15 minutes, provide you with the evidence for TASP, particular focus in South Africa, some of the scale-up challenges, obstacles and challenges, make a few concluding comments. So although Mike Cohen is not with us today, and we have him in our thoughts during this time of his family crisis, I think the randomized controlled trial evidence from the HPTN 052 study was quite a pivotal moment in this discourse around treatment as prevention. It provided solid high-level evidence in terms of, and confirmed what we'd seen from mathematical modeling data and observational studies. And we also have seen some data just now from Julio that comes from the Africa Center from a rural district in KwaZulu-Natal that shows when we provide antiretroviral treatment, not treatment as prevention, but with CD4 counts less than 350 and with a modest 30 to 40% coverage, what we see is a 11.3-year gain in life expectancy. The survival is quite significant if you look at where that survival gains is happening. It's in young people in the prime of their lives, socially and economically active, and you can see how that has gone in this particular rural community from 49.2 years in 2003 to 60.5 years in 2011. Significantly and importantly, that we've also noted a 34% reduction in new HIV infection. Building on those studies, we have the quest for even more stronger evidence, and there are multiple trials underway as we speak, and they are all testing various combinations of treatment as prevention, early versus delayed, going into the households and communities to try and bridge the gap between those seeking healthcare in facilities and the gap between those who need to know their status and be on treatment. And several of these studies, it'll be several years before we see the outcome. But even as these studies are underway to strengthen the evidence for treatment as prevention, what we've seen is a rapid evolution of the WHO guidelines from 2003. And what is important to note is as the guidelines have evolved, the coverage of the people infected has been increasing, in essence getting us closer to the 36 million people living with HIV. So in a way, the guidelines are also increasing coverage, treatment as prevention. And this morning, the South African government announced their change to increase the CD4 count for treatment initiation to less than 500. And as these guidelines have evolved, you can, including this morning's announcement, the South African treatment guidelines have also followed very closely and sometimes have gone ahead. For example, in prioritizing pregnant women for immediate treatment and those who are co-infected with HIV and TB. Another important point to bear in mind, because adherence is always a challenge as you have large numbers of people on treatment, and one of our objectives is to obtain viral suppression in order to reduce transmission rates. And this has been facilitated by the evolution of the medication. We've seen substantial reductions in pill burdens from 1 per day, right now to 1 per day, compared to several years ago where it was numbers of bottles multiple times in the day, and there's been continued decreases in cost of ARVs, and then we can look forward to in the near future, or maybe a little bit less than or more than near future, the possibility of long-acting injectables that could be given 3 times a year following an induction period on oral contraception, on oral medication, and then switching to injectables on a 3-monthly basis. I'm going to move on now to focus on issues relating to what would it take to scale this up at a country level. And I want to pay attention to South Africa because I think over the past several days and years, we've all noted the disproportionate burden of HIV infection in South Africa. Although it's home to less than 1% of the global population, it bears 17% of the global burden of infection. That translates to about 6 million people infected with HIV, and it also is the country with the largest number of AIDS cases. And since 1990, there have been annual antenatal surveys undertaken that really capture very poignantly the evolution of the epidemic and the different periods from the early phase of the generalized epidemic to the rapid spread through the coalescence of multiple sources of epidemics, and then the AIDS mortality phase. And now what we're seeing is the impact of antiretroviral treatment. So what's notable here is that since 2004, the HIV prevalence has stabilized at about 29.5%. So in 2004, we had less than 50,000 people on treatment. And you can see as year by year has gone, we have steadily increased the numbers on antiretroviral treatment. And in 2013, we had about 2.6 million people on treatment. And what is quite intriguing is how this, although there is evidence to show the survival benefits, what we're not seeing is an increase in prevalence. And that reflects two things. One is the continued high rates of new infection, but also the increased mortality from HIV-TB co-infection. And I'll talk a little bit more about that. But before doing that, I want to also highlight that while South Africa is the epicenter of the pandemic, what we have is within South Africa a diversity of epidemics. So if you go from the east coast of South Africa to the west coast, you can see here the darker areas all concentrated east coast, and then as you go to the middle of the country and much lower prevalence as you go to the west coast. So this diversity within provincial diversity, and within the provinces, what we have is districts, and there's a lot of diversity, even with KwaZulu-Natal being the leading province. Within KwaZulu-Natal, we have a lot of variability in terms of the magnitude of the epidemic in districts and within districts. Now, we've also there's another challenge, which is, and I'm just sharing some data from the CAPRISA 002 trial, which is an 8-year follow-up study of people when they just get infected. And what we see from this data, and this is several hundreds of people being followed up, that within 2 years, 50% reach a CD4 count of 350, and 80% are at that point. So this rapid disease progression kind of makes you wonder and think about how important is CD4 counts in the context of that rapidity of disease progression. Now, the other point, this point has been made several times over the past few days, is that not only do we have a huge HIV epidemic, but it's also very closely intertwined with the TB epidemic. In fact, TB is the most common presenting opportunistic infection, and is almost if you go into the TB clinics in South Africa, particularly in KwaZulu-Natal, about 70% of people with TB are co-infected with HIV. So giving you some indication of the magnitude of both epidemics and how closely intertwined these epidemics are. And we also know that in HIV-TB co-infected patients, even if you start them on antiretroviral treatment, and if that TB is not diagnosed early enough, you can have substantially high mortality rates. So moving on to what are some of the obstacles for and this is by no means exhaustive list, but if you consider what will it take to put 6 million people out of a total population of 50 million onto antiretroviral treatment. One of the biggest challenges is that the majority of those who are infected do not know their HIV status. So how do you go about trying to find individuals who are infected, who are not accessing health facilities or may not have access to facility, to find the 6 million individuals that need to be initiated on treatment? There are also a large group of hard-to-reach populations. We have a large migrant labor system still, and so you have migrant, very mobile male population, and a high incidence rate in that as they return to their home settings during acute infection. You have high rates of transmission to young women. Slim, in his opening plenary presentation, shared some of the data on the magnitude of the epidemic and the challenges, particularly in young women. You need a huge clinical infrastructure once you've identified individuals who are infected to care, and I think all of us are quite familiar with the need to strengthen healthcare delivery systems, and the other challenges around maintaining and retaining people in care. Now, adherence is going to be critically important, and not only do we want high levels of adherence for viral suppression, but also we want to minimize the risk of resistant strains emerging from suboptimal adherence level. And I think we only need to look at the TB epidemic, and notably the XDR TB epidemic that's been described in the province of KwaZulu-Natal by Jerry Friedland and others, that what can happen when you have suboptimal adherence levels, and we certainly want to preempt an evolution of extremely drug-resistant HIV strains. And I think one of the new words that has been added to our lexicon is cascades, and we've heard about cascades in all kinds of ways. And what we also know is for treatment as prevention, you need a good linkage to, once you have testing completed, good linkage to care and adherence. And there are many leaks in this cascade of treatment and prevention efforts in relation to treatment as prevention. But I think I also want to highlight that while there are many challenges in South Africa, in this paper published in Lancet, looking at the health status in South Africa and the various changes that have taken place, I think one of the most notable successes that we've had under the Zuma administration and under Dr. Motsoaledi's leadership is the strengthening of the HIV response. And we've seen almost 13 million people having HIV tests. We've seen the introduction of medical male circumcision and large numbers being offered and accessing MMC services. We've seen one of the most significant reductions in mother-to-child transmission from 9.6% down to 2.7%, and that's going even lower with more recent data. We've seen a substantial increase in antiretroviral treatment provision. It is one of the largest programs in the world. But you know, although we're covering 52% of those in need of antiretroviral treatment, there's still a gap in terms of what we can do. TB detection rates have been enhanced, and overall, how the country has benefited from these investments have been through the increase in life expectancy by 6 years. Now, we're thinking about this, we have to do this, and at the same time, we have to consider some of the financial implications. And there are large investments in the country and additional money made available for the treatment programs, both by PEPFAR and the Global Fund for AIDS, TB, and malaria. But we're thinking about expanding this rollout in the context of extreme fiscal constraints, recession looming, large decreases in the number of jobs, and large numbers of strikes that grow daily. So that's a reality we need to consider and face. But I think there's also been innovation in our response, and I want to refer to this specific one in relation to task shifting. So the bulk of healthcare delivery is by nurses, and what we have seen is by training nurses to initiate antiretroviral treatment, you can certainly bridge some of the challenges in terms of the coverage rates that need to be obtained. And what we see here is through nurse-driven provision, reductions in mortality, but also over time, what we see is not only effective treatment provision, but sustainable, effective provision of treatment. So to conclude, while we have a lot of optimism from the scientific findings on treatment as prevention, we have to balance that with the reality of implementation in an epidemic of more than 6 million HIV-infected people. HIV transmission rates are still high in South Africa, especially in young girls, and we have limited options in terms of ways that women can prevent themselves from acquiring infection, particularly young women who are unable to negotiate condom use or monogamy with their partners. And will their partners present for treatment, and will we have the viral suppression needed to impact the epidemic in young women? We have a disease progression profile where 80% will be eligible for ART treatment, even with the new WHO guidelines. And so should we even be discussing a test and treat policy in that context? And I think, there are the challenges of differences in the burden of infection across the country, particularly the high burden districts that I just showed you in the east coast of the country, but also we have the HIV-TB co-infection. And if we don't integrate the HIV-TB services, you will undo the survival gains from ART treatment initiation with the mortality that's associated with not treating both HIV and TB. There's low economic growth and a looming recession that we need to take into account as we think about scaling up treatment as prevention. And despite this, we have great achievements in the rollout of antiretroviral treatment, and we have innovation that gives us hope that this difficult task can become a doable task. And all of these, I think, can be done with political commitment, community support, and adequate resource allocation. And I think South Africa can do this if we step up the pace. Thank you very much.